way, still physically distanced, but virtually connected. Hope everyone's doing okay out there, and excited today to talk about some interesting concepts. I think we've brought some advocacy to the group here and have been excited to talk about, what the best approach is to help our Parkinson's patients out there. And the PMD Alliance continues to host these cool topics and chats. And one of the things that's been brought to our attention is sort of trying to deliver care in different care models across the world. And I'm excited to introduce Suketu Khandhar today, who is a friend and a colleague who runs a rather large movement disorder section, oversees a lot of patients. I don't know, Suketu, hopefully you can tell us a little bit about how many patients you actually are seeing across the Kaiser Permanente network up in Northern California. But it's been great to talk to Suketu about just ideas around dissemination of care, what's practical, what the barriers are in these larger organizations. And he's always been great on the wellness and holistic kind of approach to patients front too. So welcome, Suketu. How are you doing today?
I'm doing well. Thank you very much for inviting me and being here today. I also appreciate from PMD Alliance the opportunity as well. I also want to take an opportunity to say Happy Veterans Day to everyone. And for those of you who are actually on the call today that are veterans or have family members that are, thank you very much for your service.
Yeah, that's amazing. That's very important, especially because I run a center of excellence at the VA. Thank you for putting in that reminder that we should all think about every day, actually, of our existence, because we owe our veterans a lot. So tell us a little bit about your journey, a little bit about what brought you to being a neurologist, being in medicine in the first place, about your love for movement disorders, and kind of what led you to doing the work that you do up at Kaiser.
Oh, I appreciate that. So I had always thought when I was in med school that I was going to actually go into pediatrics. And to be perfectly honest, as much as I love the kids, it was sometimes hard actually navigating the questions and needs from the parents, more so over than managing the pediatric population. So I very quickly moved away from pediatrics, somehow fell across a couple of neurological patients when I was doing rotations up in Queens, New York. Interesting things that were actually a travel phenomenon when patients were seen in New York City that were not necessarily from New York City, they were just traveling from abroad, that would have these weird neurological conditions. I don't just grab my attention, and I started to recognize that a neurological exam is still arguably one of the most delicate parts of the examination and allows us to be detectives in our world. I ended up doing neurology fellowship residency up in upstate New York in Syracuse. And while I was there, I ended up getting the opportunity to go to a deep brain stimulation conference in Cleveland Clinic. This was back in 2002. And I just fell in love with deep brain stimulation. What actually drew me not only to movement disorder neurology and the fact that there were wonderful things that we could potentially do for patient care was actually the patients themselves. And I'm sure that you've noticed this in your practice is that Parkinson patients, and no offense to anybody else with any other neurological conditions, but they are hungry, eager, wanting more for themselves and their loved ones. And it was inspirational. I think that level of inspiration drives me and sort of gives me the quote unquote why as to why I do what I do. And I was lucky enough to be able to do a 2-year fellowship at UCSF up here in San Francisco. And then back, 15, 16 years ago, joined the Kaiser system in Northern California. And currently I'm the medical director of the Parkinson program.
That's amazing. That's really great. How many patients do you guys take care of? Do you have an estimate of how many Parkinson's patients are in your system?
Well, I don't have the exact number, but it's roughly around 10,000 patients in Northern California, Kaiser with Parkinson's. The thing is, we have our own internal databases, and we're able to very easily extract and analyze that data. So we have about 10,000 plus or minus. It may have shifted somewhat with the pandemic. We've had, unfortunately, a lot of commercial-based patients leave the Kaiser system because maybe a loss of a job or loss of insurance, and a few more Medicare patients basically join. But I'm not sure exactly what that is. In my own personal practice, I have 1,200.
Wow, that's a lot. So you know about Parkinson's.
I've learned a little bit along the way, I would like to think.
That's cute. Well, I know you have prepared some slides for us, and we've had a look at them together. And I think this is going to be a cool discussion, robust discussion about multidisciplinary team care, because I think that we both feel that just having the doctor alone in a silo is not enough, that we need to really be thinking about other members of the team. So maybe I'll let you share your slides and we'll go from there.
Sounds great. Let me go ahead and do that now. Can you guys see my slides?
Yep, perfect.
Perfect. I'm going to go ahead and just start the slideshow then. All right. So, as we kind of alluded to, the conversation we're going to have really kind of revolves around defining what a multidisciplinary approach looks like. And I want to first share with everyone who's on this call right now is basically what I'd like to define as an informed patient, someone who basically already feels empowered, wants further empowerment, wants to seek appropriate care. But the reality is that most of you who are on this call really represent the minority of the PD population. The vast majority of people in this country, even within networks like Kaiser's or who have the ability to be able to access care at UCLA and the VA medical centers are still unfortunately not empowered to the same degree that many of you on this call currently are. And that represents a little bit of a challenge. I mean, does this really reflect the lack of care that's out there, or does it reflect the lack of structure for that care that's out there? And I think these are two things we have to appreciate and understand that within the various networks and care delivery models that we have in California and across the country for that matter, there are going to be financial and healthcare limitations on how to deliver that level of care. I actually added this slide in here called New Kid on the Block from a talk that I'd given at the World Parkinson Congress back in 2016 when I was in Portland. And I kind of stole from that same slide that I created, but I want people to recognize that movement disorder neurology, there are not that many of us, right? Within the Northern California Kaiser Network, we have roughly about 160 neurologists, 160, of which only 8 are fellowship trained in movement disorders. That means the other 152 are more or less acting as specialists in other fields of neurology or simply general neurologists, and their level of expertise in Parkinson's disease care is not the same. So I find that I have to redefine exactly what it is that I do because patients are not quite understanding what the difference is between a movement disorder neurologist versus a general practitioner in neurology. And the 3 big things I want to identify, if you look at the red here, is, I basically help to pattern a diagnosis, help to educate, and help to connect folks with local resources. I find that these are probably 3 of the most important things that I do. It's not all about medical management. It's about making sure that we create a community level of support and create a culture of community surrounding the needs for somebody and their family living with Parkinson's. So current ideal world, and some of this taken from our colleagues out at the Parkinson Foundation, but before when it was NPF, is that ideally we would love to have every single patient diagnosed with Parkinson's be followed by somebody who has expertise in Parkinson's, i.e. a movement disorder specialist, whether it be a physician or a nurse practitioner. And that be that neurologist that steers the full level of care for that individual. And that there be a full care team to support the needs for that individual. Because as Indu had alluded to, really this condition cannot be managed by any one individual. It really does require a team effort. But the reality is that up to really 40% of folks don't even see their neurologist annually. And less than 25% of individuals even ever see a movement disorder specialist throughout the whole lifespan of their condition. I mean, if you take a moment, take a step back from that, right? 40% only see their neurologist yearly. What about the other 60%? Who are they being followed by? Are they being followed by a neurologist every few years? Are we allowing the patient and their care partners to assess when the need arises to see the neurologist? Or are they being followed by somebody entirely different, like a primary care physician? And the fact that only 25% ever in the whole course of their condition see a movement disorder neurologist, that to me is appalling, embarrassing even. That means that something that is as sort of complicated and delicate as Parkinson's disease, 3/4 of patients never see the specialist. Now, this is data taken from our Kaiser Network in Northern California a few years ago of people who had diagnosed idiopathic Parkinson's disease, and it was taken from a certain cohort, so it's not the whole population. But what we did was we looked at how many of the patients were seen by general neurologists and how many patients annually were being seen by movement disorder neurologists, and it was an 80-20 split. Again, quite embarrassing, and this is back from 2012. And so we decided that, you know what, we need to restructure our care in the Kaiser Network. And a lot of this work was actually sort of parallel with the work that Professor Bas Bloem has done up in the Dutch Netherlands called PDNET. Some of you guys are quite aware of PDNET, where they basically restructured the care delivery in the Dutch Netherlands, sort of carving up a lot of the areas in the Netherlands, and then within each of those areas, identifying who was being able to deliver expert care for those people with Parkinson's, not just the movement disorder neurologist, but the physical therapist, the speech therapist, the occupational therapist, the mental health expert, and then collecting all of them together and giving them the patients to be seen with Parkinson's, basically elevating their level of expertise and experience. So we decided that within the Kaiser Network in Northern California, we were going to do something similar. Number one, and these are basically the rules we wanted to follow by. All patients with Parkinson's should be diagnosed by a neurologist, not by anybody but a neurologist. It doesn't have to be a movement disorder specialist, but at least a neurologist. You'll be surprised how many are not. And that all patients with PD are routinely seen by neurology on an annual basis. And we're holding ourselves to these metrics, by the way. And in addition to that, every single PD patient has to be seen routinely by a neuro PT, not just any PT, but a neuro PT. Now, I'm going to give you guys a quick 1-minute spiel on physical therapy. Most physical therapists that graduate from therapy school are more or less orthopedically trained. They may have had 1 or 2 months of neuro PT in their training, but that's about it. If you truly want to become a neuro PT, you got to do an additional year of training in neurology. And for those people who really want subspecialty training in Parkinson therapy, they're going to have certifications in LSVT Big, Power, Bootcamp, Tai Chi, Yoga, Rock Steady Boxing, all these wonderful programs that have sprung up over the years in order to be able to tailor the therapy approach towards Parkinson, towards a particular Parkinson patient, because as you guys can all imagine, it should be different from individual to individual. So in doing this, how are we going to be able to leverage our expertise, right? I mentioned to you before that we only have 8 Parkinson specialists. How do we train up our general neurologists? And how do we reach every single patient? And the good thing is that at least Kaiser was somewhat poised in being able to deliver telehealth care, even before the pandemic, right? We were all sort of, the pandemic has been somewhat of a catalyst for us to be able to leverage telehealth visits. But the reality is many organizations, including the VA Medical Center, I know Indu has probably been doing this for quite some time, have utilized telehealth visits to reach a certain population that otherwise was not able to come in. And so we've used telehealth in a way that we already understood prior to the pandemic, and the pandemic just more or less catalyzed this to a much larger degree. We also then went ahead in the Northern California section and we put together for our general neurologists a 14-page sort of playbook on how to deliver evidence-based routine care for certain non-motor symptoms of Parkinson's disease. Now, mind you, every time you go see a patient, or every time a patient comes to see you, rather, the focus is always on the motor symptoms, right? It's always on the tremor, on the stiffness, on the slowness, and you almost always focus your care delivery on that as well. But what about the speech issues, the swallowing issues, the bowel issues, the bladder issues? Most general neurologists not only don't know how to address that, they don't even know to ask the question. So therefore, I think that there's some degree of onus on movement disorder neurologists if they want to deliver better care throughout a whole network, that we have to take the initiative to educate our colleagues. And so we developed this sort of playbook in Northern California Kaiser about 3-4 years ago, and then every year disseminate this information and update this information to our general neurologists so they can give and deliver the best care possible. Now it comes to developing a care team. This is what we think is the bare minimum that is required for good multidisciplinary support in Parkinson's. And keeping in mind the patient is always the navigator of this team, not the primary care physician and not the neurologist. Oftentimes we think of a team and we think of the neurologist playing the role of the driver. Yeah, they can be the driver at times, but the driver is going to change. But the patient should always be the navigator. The patient's always sitting in that passenger seat and always the one playing with the GPS, if you understand the analogy. And that's how we feel that the care should be delivered, right? As the patient, you may not necessarily know what to do from a driver perspective, but you need to appreciate where you want to go and therefore rely on the driver to get you there. And sometimes that driver needs to change. Sometimes it's the neurologist that's in that driver's seat. Sometimes it's the primary care physician. Sometimes it's the physical therapist. But these 3 providers are going to be your core care team from any care delivery system, and then a support network locally to sort of support some of that might be outside of your network. Now, in Northern California, that might be the Parkinson Association of Northern California. If you're living in the Bay Area, there are several other wonderful support networks. Or if you're on this call, you're using PMD Alliance, right? And your care team over time is going to have a few things that they're going to start to develop. And I'd have to actually emphasize the top 3. They have to have expertise in Parkinson care, right? We mentioned that before with the movement disorder specialist or in well-informed general neurologist, have experience because now they're seeing more and more Parkinson patients, and then have the passion passion to want to move the envelope or move the ball forward, whatever the proverb is. So what are the things that these folks are going to basically do for you as the patient? So let's start with the neurologist. For me, the neurologist, and I had mentioned this before, is going to do some of the PD management, the med management, but also education. The primary care physician is going to manage all the non-PD concerns and should very well be receptive to talking to the patient about certain concerns. All too often, I find that primary care will say, oh, that's just the Parkinson's talking, go see your neurologist. Well, no, the ingrown toenail is not Parkinson's. You got to take care of that. That has nothing to do with the Parkinson's. Or maybe it does, because the ingrown toenail is happening on the foot and they're having toe curling dystonia. But the reality here is that I think the primary care should be receptive, open, engaging, and accessible. Now, the physical therapist should be able to establish a structured, tailored, I should probably write that word in there, tailored exercise program. Remember, everybody with Parkinson's is a little bit different, right? You all started with slightly different symptoms, had a slightly different response to medication, and a slightly different need then for therapy. And your compliance with that therapy also has to be sort of tailored to what you would like to do. And then we get to the social network and we talk about establishing a sense of community. And I'll get to some of this in just a second. There's also a larger care team, right? We talked about here, you and the core care team down here. But within these concentric circles, you also have speech therapy, occupational therapy, and mental health, which is going to be just immediately surrounding your core care team. At times, you may need a urologist for increased urinary frequency, or a GI specialist for pretty debilitating constipation, or a neurosurgeon for if you're considering deep brain stimulation surgery. And there's a whole host of community-based programs that are out there as well. This becomes your larger care team that you start to sort of employ when the need arises. And you, as the navigator of this care team, should have the sort of the ability to kind of pull those strings when you see necessary. Now, this is the algorithm that our physical therapists in the Kaiser Network, Northern California, go through when they see somebody with Parkinson's disease. And so we're going to spend a couple minutes on this slide particularly here. And we have actually highlighted this slide at national organization levels, as well as at the World Parkinson Congress. So number one, it's really, really important that everybody diagnosed with Parkinson's by the neurologist have an early referral to physical therapy. Early referral to neurology, and then early referral to physical therapy. It is not uncommon that when I make a diagnosis of Parkinson's, I may not start medication right away, but I'm going to send you to a physical therapist. Even if you're someone that bikes 3 days out of the week and runs ultra marathons, I'm still sending you to a physical therapist. Even if you're someone that says, no, I'm pretty active, I work in my yard all the time, and I'm the one who's growing all the plants back there. No, that's great. It's wonderful that you're active, but can we sort of add to your activity with appropriation of physical therapy that's specific for your Parkinson's? So we're going to have the neurologist make the referral to the physical therapist, specifying what the symptoms are that the neurologist is recognizing that actually lends to the diagnosis. So it already gives some information to the physical therapist so they don't have to start from scratch. Number two, the physical therapist will do a one-on-one physical therapy appointment with the patient. And at that point, they will do their formal assessments, whether it be a unified Parkinson disease rating score, whether they do a Berg balance scale test, a sit up and stand, walk and sit test, a timed up and go. They will do all these tests to be able to get a baseline as to how they're doing, right? And are there gaps? Are there ability and opportunities to be able to make this better? We believe that that type of visit should happen on an annual basis. And furthermore, I believe that visit should happen with the same physical therapist every year. I want to emphasize that, the same physical therapist every year. Before I joined Kaiser 15 years ago, you'd get a referral to physical therapy when the provider thought the need arose, not when the patient thought the need arose. And when you saw somebody in physical therapy, you may or may not see somebody who's trained in Parkinson's, and then you may not see the same person each time. That means each and every time the 50-minute or 1 hour visit you have the physical therapist is half spent, we're trying to reinvent the wheel. Well, if you've already seen that same neurophysical therapist and they start paneling you on their panel, well, how wonderful is that? They already know you. It's an annual well visit with them. They don't have to reinvent the wheel. They've already seen you. They look back at their notes and go, oh yeah, that's what I did with you last time. Great, let's go ahead and start there. They're not having to backtrack at all. And now you've optimized the 50-minute or 60-minute appointment with them. We also actually developed a monthly exercise as medicine class. that's being held in every major physical therapy area in Northern California, Kaiser. This is a 90-minute PowerPoint presentation that's given by the physical therapist, by the neuro PTs, to a group of patients with Parkinson's and their care partners. They used to be in person, now it's done virtually, given the pandemic. But we realized that this level of information can be delivered by the neurologist, but unfortunately for many of us, many patients find us as neurologists a little bit intimidating. And to be perfectly honest with you, most of my movement disorder neurology colleagues are not able to deliver this information in an empathetic way. Neurologists have not been known to be the most empathetic of people. We sometimes have been labeled as having a stick up our you know what. And therefore, I think it might be a lot better to be able to deliver this information from someone less threatening and someone who's actually going to be doing this work with you. So this has been highly successful. In fact, actually the PowerPoint presentations that we put together in Northern California were adopted by Southern California Kaiser. And we probably have no less than 20 to 40 people every month. And every year, some people come back to learn again about it because we actually update this information every 6 months. Once they've had their exercise as medicine and their one-on-one therapy visit, then it starts to become, do we have these folks go to a community-based program because they're doing really well? Do they come to exercise group class? We know very well that group classes motivate folks a lot. So therefore, we've actually started these exercise group programs at high intensity, medium intensity, low intensity, only gait. Do they actually go to community-based exercise programs, or do they continue doing one-on-one therapy just because of fall risk? And then this thing cycles again and again on a year-to-year basis. So this is more or less the structure that we've developed that we feel is most important for our patient population. And we also feel by involving ourselves in this, we are hopefully going to reduce falls, reduce ER visits, and reduce fractures. Unfortunately, there was some data that I wasn't able to share with you since it's proprietary information on Kaiser, but we've basically been able to reduce ER visits by something like 40 to 60% over the last 5 years by employing this type of program. So it comes down to what envelops a successful treatment strategy. And for me, and I gave this talk at the Parkinson Disease Foundation a few years ago, it really boils down to 3 very simple but equitable things. Number 1, right treatment with medications, the right dopaminergic medications, right? Arguably, Parkinson medications tend to be the most complicated of all neurological therapies, making sure that you're on the right dose, given at the right time, given in the right way, right? Taking that, for example, 30 minutes to an hour before you take your meal, so that way it actually is absorbed appropriately, or crushing it when necessary, or having a little orange juice with your medication so that the acidity level allows for better absorption. That's just really 1/3. And yet most neurologists, right, most providers, when they see you in clinic, are focusing almost entirely on just this. 1/3 should be dedicated to the right therapy program and the right exercise program. So I'm actually giving the same level of importance to therapy as I am to dopaminergic treatment. Because for me, therapy is medicine. But now 1/3, I'm also putting some ownership on an individual, right? All too often in medicine, we tend to practice parenteral medicine, which means that like a parent, I tell you what to do. Well, at least I do with my kids. But this is really a partnership, right? There's a partnership and a level of trust that has to be developed between patients and their provider. And so on one end, the provider should have the trust of the patient to be able to make sure that they're getting the right level of dopaminergic treatment, that they're going to the right therapist, they're getting the right research-based information, and they're actually getting enough resources to be able to help with whatever we can help with, given whatever resources we might have. But there's a certain amount of ownership that being put on the patient to accept the diagnosis, to be able to embrace the diagnosis, to be able to make sure that their appointments are being scheduled on an annual basis, right? And to make sure that they follow through with that they also empower themselves with understanding and education, which of course many of you are doing right now simply by being on this call. But to me, this is of equal importance to the other 2. And you put all 3 of these together, and now you got the whole pie. So again, a very simple recipe for a successful treatment strategy. Some of this, like I said before, does evolve outreach. And I think there's just as much importance on the sense of the provider to understand what is out there, whether it be PMD Alliance, or in Northern California, the Parkinson Association, the Bay Area support groups. I don't know if you guys know, but we actually sponsor the only ballet program for Parkinson's in Northern California through the San Francisco Ballet. And they actually do now virtual programs twice a week completely supported by, well, nearly completely supported by the Kaiser Permanente system. We partner a lot with the Parkinson Foundation, the Brian Grant Foundation, the Davis Finney Foundation, as well as the World Parkinson Coalition. And actually, for many years, we've had a partnership with the Sacramento Kings. May or may not be your favorite NBA team, but it's our local team in Sacramento, our only national team in Sacramento. So therefore, we partnered with them, and for years, along with the Brian Grant Foundation, actually held a Parkinson disease awareness night, which of course doesn't happen now given the pandemic. With that, I was going to open it up to some questions and some dialogue with Indu, but I wanted to actually thank my whole team in Northern California. This is all of our neurologists, our nurse practitioners, and our neurosurgeons, as well as our support staff. And so really, I'm nowhere without them. So thank you for giving me your attention for a bit. I guess I'll go ahead and relinquish the...
Yeah, stop sharing. That'd be great. That's great. I think that's a great overview of what you guys are doing, and really some powerful collaboration there and some great work. So I think there's been some questions here and a lot of interest in, sort of some of the educational things that you guys have been putting together. So one question is there a possibility that patients could access outside of the network, this neurology website, or are your patients able to access the TPMG neurology website that the providers are using? Is that like in some
No,
sort of
that unfortunately is just amongst the providers. Trust
Okay.
me, I've been wanting to make it patient facing, but administrators are administrators, and they find this information somehow proprietary, and I find it should be very ubiquitous. I feel like it should be open to everyone, but yeah, I'm unfortunately bound by that.
Yeah. I mean, I think when we put a lot of work into developing some of these materials that, especially in the non-motor realm, a lot of the patients are so hungry for them, and it's relatively easy to make them patient centric, and take out some of the verbiage that might be a little bit, more, doctor lingo. But I do think that these are resources that could be tremendously helpful to our patients. And like literally within the first minute of you showing it, somebody had asked that question. Another question was about whether your exercise as medicine videos, which presumably now are, because of the virtual space, have been maybe recorded, if that might be something that could be available also to non-Kaiser patients, or some version of it might be even possible to present on this type of forum, so we can put it up, and
I'll have to find out about that. I think that, Kaiser being a closed system, a lot of stuff that we do within the network is available only to those people who are also within the network, right? But I think that Kaiser is kind of shifting its view and recognizing that some of the successes that we've had within our system should be shared outside of our system. So I think more to come regarding that. We've always been open to wanting to share that and make it much more patient-facing. What we did actually was using some of that information that we created in Sacramento, we developed a program called Parkinson Wise that very much paralleled the exercise as medicine classes that were given by the neuro PTs. And we gifted that education to the Parkinson Association of Northern California. And that was our opportunity to be able to, take away the Kaiser logo from it and just put the Parkinson Association logo onto it and let them deliver the same content using neuro PTs from Kaiser to deliver it. But therefore, we weren't necessarily then bound by having to answer to higher ups that, why aren't we opening this up to non-members within the Kaiser network? But I think in the next couple of years, as Kaiser now has developed a medical school in Southern California, as you probably are aware of in Pasadena, I think you're going to start to see some of this opening up to non-members.
Yeah. I mean, I think it's rich information, and I think we're all trying to do, I think we all ultimately went into medicine to help all our patients, globally. And so I think, that would be amazing. And yeah, we would love to host, even if it could just be for an hour, the person who speaks at that, maybe we could have them on here and they could share some of the ideas and tips.
Well, I have a wonderful person. Well, I have a wonderful person for you. Just email me separately, and the neuro PT that basically sort of conceived of all of this, I'm sure should be happy to join you, and then kind of run through all your audience on what that sort of class would look like.
Perfect.
She works a lot with Bas and his group up in Netherlands, by the way.
It's not Becky Farley, is it? Because she came on.
No, it's not Becky. It's a neuro PT by the name of Erin Vestal, and she's a Kaiser therapist up in Roseville, California.
Oh, perfect. Okay. Yeah, we're always open to having neuro PTs on. We love them. We've had like 3, I think, on, and they've been much loved. So that's awesome. Yeah, so I mean, I think there's been a number of things, other questions in the chat. One is, when we talk about these team leaderships and that, I think we do really believe that the patient is in the middle. But, unfortunately, with the way that, the the healthcare system and the insurance, and I don't know if it's a bit different at Kaiser, but certainly at the VA, even though it's a closed network, there is, issues with the same thing, is that, only physicians or doctors or, sometimes nurse practitioners can actually prescribe therapy, for example, physical therapy, for example. So you are sort of in that sort of loop of needing the doctor to sort of sign off on things. Is that still the same? You sort of showed these boxes of people, entering physical therapy at different places. Is the therapist able to renew their own therapy, or is it always going through
Um,
the doctor?
yeah, so actually our therapist, if a patient contacts our therapist and says, hey, I think I need to be seen, and I know it's only been 3 months since I last saw you, all the therapist has to do is say, okay, actually schedule them for an appointment, and then sort of back order a referral from me. So there is
Okay.
a step that I have to put in there mainly for reimbursement purposes, even
Yeah.
internally. And so I can't get away from that. It just means I'm going to have to put in more referrals. That's not a big deal. I probably do these about a dozen times per day, simply because our patients need more therapy than we're originally able to deliver with just one sort of series of therapy in a year. So we usually have our therapists connect with these folks every 3 months. And I think in the chat along those lines, there was a question about somebody actually, why are you doing movement disorder visits only once a year? That's the bare minimum. We're holding ourselves to the bare minimum because so often people are not being seen even once a year. But the reality is, in my practice, I see my patients a minimum of twice a year, connect with them by email, sometimes on a monthly basis, and then I have a nurse practitioner who sees them if I'm not able to. So it ends up
Yeah.
being about 4 to 6 connections per year. But
Yeah.
the visits that we're holding ourselves accountable for is once a year.
Yeah. So at least you're saying that the standard of care should be at least once a year. If you're not being seen once a year, then there's a real problem with that. Yeah. And are you able to track that then throughout the system? Are there metrics to make sure that patients are being seen by different folks once a year? Or is it sort of up to the group that's seeing them to
No,
figure that?
actually, we're tracking that information. Yeah,
Great.
we can
I think
track it internally, particularly if you're a Kaiser member, right? Because all you have to do is you have an internal database with an analyst that just has to look at the ICD-10 code when they were last seen, who they were seen by. It's a pretty
yeah.
simple analytic metric.
Yeah, no, and I think that data will hopefully help other healthcare systems as you guys get more information about, because that's what sort of drove Bas Blom and his gang to be able to, circulate this information on an international level, is that they showed that there was a reduction of, I think, hip fractures and cost ultimately, and hospitalizations for their patients. So I think it's such a cool model, and it's great that you guys are piloting it as one of the only real sites in the United States, even this many years later. Is that correct, as far as I know, or have you heard of other places?
Yeah, I think that there are many other systems that are trying to navigate it. The problem is that they don't necessarily have the resources. Since Kaiser is a fairly closed system and we actually have nurse practitioners in our practice, we have physical therapists within our practice, not being outsourced elsewhere, it made a lot of sense to replicate it. So Bas actually approached us, 6 years ago, maybe, back when that British Journal of Medicine actually came out with the revolutionary new way of approaching Parkinson article. And so they first engaged Southern California Kaiser, and they sort of replicated a Parkinson Net 2.0, and then we did a Parkinson Net 2.0.1 up in Northern California.
I can't.
Sorry about that. I'll send you a continue. Sorry about that.
All right, no worries. So another question, Suketu, is the nurse practitioner role. Is that, could you define that a little bit for us in the Kaiser sort of system?
So we have 8 movement disorder neurologists and 3 nurse practitioners. As probably people know, nurse practitioners are able to assess folks without the need of a physician to support, and they're able to actually manage medications and prescribe, unlike at times certain PAs, which are physician assistants. And so having a nurse practitioner to complement the movement disorder clinic makes a lot of sense. To give you an example, in my particular clinic, I have a full-time nurse practitioner that she is there when I am, and she's also there when I'm not. She actually addresses all of my inbox needs, like patient emails, phone calls, medication refills when I'm not there. For example, if I'm at the movement disorder meeting or something. But I also have her follow up with patients if I'm not able to see them in a timely manner. So they pretty much work at the same capacity that I do, but they don't do new consults. I think that skill set should still be reserved for the movement disorder neurologist, simply because we may be looking at things a little bit different than NPs are. But, and if you look at the sort of cost efficient use of a nurse practitioner, you can basically pay 2 nurse practitioners to the job of 1 physician, right? So it makes a lot of sense for nurse practitioners to complement a specialty clinic in probably every aspect of neurological care, not just movement disorders. I know in my clinic up in in Sacramento, we have 15 neurologists, some of which are epileptologists or MS specialists. They all have nurse practitioners too.
Yeah. Yeah. No, I think that expanding our horizons a little bit, but I agree. I think that the intake, just for the first visit, just to clarify the diagnosis, because I think this is a diagnosis that is not terribly easy to make in many situations. And there's not one blood test or something like that. You really have to kind of go through with a fine tooth comb and verify that you're dealing with, regular Parkinson's versus these other sorts of disorders that could masquerade as Parkinson's. So I think that's a great idea. Do you guys have a support group specifically within the Kaiser? You talked about the physical therapy sort of groups and meetings, but is there like a Kaiser-wide support group, or are these sort of just using the local resources in the community?
So in Sacramento, we have a deep brain stimulation support group. About 10 years ago, I recognized there was no such thing as a DBS support group, at least in NorCal. And so we created the first one. We do it on Kaiser property, but it's actually facilitated by patients and my nurse practitioner. And then they call upon specific speakers. We also have a young onset support group as well. However, the remaining support groups are actually with the local Parkinson Association or the other support groups that are out there, and we refer patients to them.
That sounds good.
For me personally, I think a support group should be facilitated by patients and their care partners, not necessarily by providers. Providers can be asked to come speak, but that doesn't mean they should run it.
Yeah. And then you guys do like a yearly meeting, right? Like what types of meetings are you having for patients? So I know that is that the one is that the San Francisco region? It's not a Kaiser meeting, or what? Because I remember that you were telling me about that.
Right. So the Parkinson Association of Northern California for over a decade now has basically supported an annual patient-facing educational conference. It's usually held in the month of October. We just had it a couple of weeks ago. Almost always with local expert speakers, a few invited speakers from outside of our area, and always a keynote being given by somebody with Parkinson's or their care partner. There's always a panel discussion afterwards with a variety of folks from different disciplines that's being organized and orchestrated by a movement disorder specialist, being able to field questions like we are now. This couple weeks ago, we had about 1,000 people attend virtually for this meeting that we held. That will be made available on the Parkinson Association, not the Parkinson Foundation, but the Parkinson Association of Northern California website starting January, once they kind of cut and paste all the different things that they filmed. But otherwise, next year, we have Jimmy Choi, who's going to be our annual speaker, our keynote speaker. Last year, Brian Grant was our keynote speaker. David Leventhal actually spoke a couple of years ago. Dave Iverson actually spoke, Becky Farley spoke. So we've actually had a wonderful array of keynote speakers that have just inspiring to the audience. So this is a big program that we have up there that's almost always in person. And this year, because of the pandemic, we went virtual, and it was interesting to understand how we could leverage a virtual program.
Yeah, it is interesting. I think you can kind of get it out to more people, and then having this on video is great too. So, and then presumably anyone can watch it off the Parkinson Association of Northern California website once it's up in January, so people can stay tuned for that. And there's just been a couple of more questions clarifying about nurse practitioners. So is there's a certification for nurse practitioners in Parkinson's disease, and is there a movement disorder specialty for nurses or nurse practitioners in Parkinson's disease?
So if you look at the structure for nurse practitioners, once they graduate after having done the training for nurse practitioners, they're basically general nurse practitioners. They can go into any field of medicine, and they're all more or less almost kind of grandfathered in to be trained by the people they're working with. There is a neuro nurse practitioner, but it's not necessarily specific for movement disorders. So within my department up in Northern California, we have 8 nurse practitioners, one of which is an epilepsy nurse practitioner. All she does is epilepsy. One is an MS nurse practitioner, and I have my movement nurse practitioner. It took me 2 years to train my movement nurse practitioner. Seeing patients with me, proctoring her on patients independently, and then with her, having her be certified in how to actually deliver the UPDRS 1 to 4, how to appropriately videotape patients, how to make appropriate med adjustments, DBS programming. It took about 2 years. But
Yeah.
unfortunately, there isn't a structured training program. It just was done by yours truly. But I would imagine the same holds true anywhere else for that matter too, right?
Yeah, I mean, so I think there's a few other resources. I mean, I think some of the smaller communities around the country, and I know like when we had Becky Farley come on, she was talking about, some of these physical therapists that are working in these very small communities rurally. They've been able to approach her organization, for example, with the PWR,
Right.
and then they'll go out and train some of the people in that local thing. Presumably now that they're doing a lot of virtual training too, that's an option. And then there's these allied team trainings with the Parkinson Foundation that
Right.
basically allow, I think, a center of excellence, Parkinson's Foundation Center of Excellence, to host sort of a training and have these multidisciplinary folks come in. Even like a whole team can go there and train kind of about what the different possibilities might be. Because I think, thinking outside the box with these different models is important. And when Mike Oken and Bas Bloom were talking about their work with the Ending Parkinson's Disease book, one of the things that was really striking was some of the similar statistics that you had showed, which is that a lot of our patients with Parkinson's don't see a neurologist, let alone a movement disorder doctor. And I think somebody had written that 60% of the levodopa prescriptions are from primary care doctors in the country. So I think we really have a lack of in this basic training, disseminated across the country would be so important, because we just have a lack of these subspecialists. And it is, a lot of time when you go through neurology training, and then to add 2 more years on as a Parkinson's doc, training is asking a lot of folks that might be coming out of residencies with, debt and, needing to start joining the workforce. So I think finding ways to disseminate information to general neurologists and using these nurse practitioners and other folks that might be in the community to the best of our abilities, even, and I think, again, letting the physical therapists have the best training so that they can work with this in a disease specific way is really, really helpful, I think, as well. Are there other things like health coaches or personal trainers within the Kaiser system that you found helpful?
No, we have neither. We actually use a lot of community resources for that. That was actually part of the reason to develop that Parkinson Wise program I talked to you about before, because through the Parkinson Association of Northern California, they basically deliver the Parkinson Wise training. But anybody who is a personal coach, a life trainer, a non-medical therapist, like let's say Pilates trainer, for example, can all come and be sort of trained on this, and then be certified in Parkinson Wise, and then be able to become that life coach or that personal trainer for that individual, not necessarily within our network, but outside our network.
And if we have folks on the call that are in these sort of places that don't have access to many of these things, I know it's frustrating sometimes to hear about these awesome sort of systems that are closed care that have all these different resources. And, it's hard for you even in some places to even get to see a doctor, let alone anyone else who knows anything about Parkinson's. I think that, getting to know what sort of these trainings could be, so that if you identify a champion in your community, that might be even, physical therapist or a nurse or somebody, I think it could help to train them so that they become a leader in some of these sorts of things and connect the group to some other resources. I think there's always educational resources. And I think now with the virtual rollout, I think, all the more possibilities for people to join from, many, many parts of the country. Do you find that most of your patients have access to internet and are able to use the virtual modalities?
So, I work out of Sacramento, and a lot of patients I see are coming from anywhere south of Redding to some of the more northern parts of northern Nevada, or the Central Valley in California. I'd have to say about a good 20% of folks don't have access to technology in the way that we need them to deliver telehealth. It's for that reason we actually kept our clinics open during the pandemic, even in the height of the pandemic. I don't think it's fair to those individuals to cut them off completely, because what we're noticing is that those folks who unfortunately were cut off and were sort of kind of forced to postpone their appointments that would have been seen at that time are now coming in crisis. And if we had been able to see them more uniformly throughout, not just Kaiser, but even at the other healthcare systems in our area, it would have been of value to them. And so, at least for me in my clinic, I never entirely went virtual. At the best, I went 50% virtual. And so I kind of went against the guidelines in some ways, just got the appropriate PPE, and patients did the same, and their care partners did the same. But I saw patients that needed to be seen.
Yeah. No, I think that that's so important. So, I mean, I think that your concepts of having the PT sort of be the point person and having them get to know the patient well, also, it makes so much sense to have the same PT over and over rather than, like you said, reinventing the wheel. With I think that intake takes so much time, and it's really kind of a wasted resource if different people are, but I found there's been pushback to be able to get that to happen at the VA. So I really applaud you for that. And a few other questions in the chat. One is, I know you may not know the answer to this, but the Southern California versus Northern California, are they pretty similar in terms of their offerings in this regard, or?
Yeah, very similar. Just the structure and the sort of ingredients are very similar. How we've structured it is that, if a primary care physician is suspicious of Parkinson's, they don't make the diagnosis, it comes to neurology, we make the diagnosis, we send them to neuro PT, and then between neuro PT and movement disorder or general neurology, we manage the care moving forward along with the primary care physician. In Southern California, Kaiser, it's very much the same. They still offer the physical therapy, they still offer the group classes, at least outside of the pandemic. They still offer movement disorder neurology when necessary. But I think there's just subtle differences between how they deliver it in Southern California versus Northern California. And I'm not fully aware of what those differences are. I just know that there are differences. There are 6, maybe now 7 movement disorder neurologists in Southern California Kaiser, from Sunset Kaiser to Fontana to Irvine has one, San Diego has 2. But I think one of the biggest issues in Southern California Kaiser, to be honest with you, is geographical limitations, right? Your Southern California Kaiser folks that are in San Diego are in some ways very cut off from the ones that are in the sort of the LA basin, simply because of traffic. So you don't see the same degree of sort of connectivity and collegiality down south as we do up in Northern California. We just have a little bit less traffic, I think.
I don't know if that's true. I've been stuck in some pretty bad traffic. Who knows? Maybe you guys are just a little bit more collegial. I'm not sure, but yeah, I think it is complicated to compare, I think, one area to the other. There's a question here about the California PD Registry and how you guys are participating in it and what you think about it.
So first of all, I think the registry is a wonderful idea. And as everyone on the call probably knows, many years back, 15 years ago, there was an attempt to actually create a registry, but it was done through the DMV. And that was a terrible failure, simply because people were worried that they were not going to be able to drive or lose their license. The new registry, which is actually a little bit more thoughtful, kind of based upon the work that's been done in cancer registry, is really an ability to collect demographic, epidemiological information on who has Parkinson's, where they live, and the validation of whether that is being done by a neurologist, movement disorder specialist, and tracking that over time. Right now, if you think about it, we really don't know where our patients are. I mean, in Kaiser, it's a little bit different simply because we have Northern and Southern California Kaiser has our own little databases. But outside of that, where are the population heat maps for California? Where are our patients? I mean, I won't be surprised if the registry, when it's done and the data is collected, that we see sort of certain areas in California where there is more specific higher incidences of Parkinson's, maybe because of agriculture, very much in line with the Ending Parkinson's book. My involvement is that I actually directly consult with the Department of Public Health, simply because I work in Sacramento, and that's where it's out of. Mark Damison is actually the director of the Parkinson's Disease Registry for California. I helped, at least in Northern California Kaiser, and a colleague down in Southern California Kaiser did the same, work with our Kaiser counterparts in region to be able to identify analysts to deliver this information straight and directly to the Department of Public Health, so that providers themselves don't have to, because one of the biggest limitations of the registry is basically submitting this data. So a lot of people who are working in private neurology groups just don't have the time to be able to submit this information on every patient they have. If I have 1,200 patients in my practice, there's no way it would be a full-time job for me to submit this information on every single patient every time I see them. So the fact that at least our network supports submitting this information, and now it's law, it's Senate Bill 97, I think that we were bound by the ability to send it, and it's great. And I'm hoping a couple of years from now, we have quite a bit of data that comes out that allows us to understand where our patients are, maybe giving some insights as to causality, and maybe allowing us to have some argument and cases against the use of certain products when it comes to the genesis of PD, and being a research opportunity for patients.
Yeah, Absolutely. I think it's an interesting concept, but I do think it has to be, I think in these bigger systems where we can dump the data, it's very practical, but having having to have the doctor individually do it makes it, quite
Mhm.
impractical, I think, in some other settings. So there's been a few questions just about, a number of things. I don't know that we'll get to all of these things, but I know that you are of the same mind as me in terms of some of the holistic approaches to Parkinson's, and maybe you could tell us a few pearls just about who are the patients that you feel do the best, what maybe if there's a secret or two sauce of that you prescribe. You've talked about exercise as medicine, so we won't go to that one, but even diet, things like that, if there's other things that you think really make a difference. And then there's a question that's been repeated a few times about fatigue, and if there's any pearls that you might have on fatigue.
So let's start with the fatigue one because that's a little bit more concrete. I think that fatigue is very multifactorial in Parkinson's, and it's a reflection of not just having fatigability because it's a degenerative disease, but actually having the provider take a little bit of time sitting down with you about how well you sleep at nighttime. Is that fragmented sleep? Are you getting good medical management while you're sleeping? Are you sleeping a lot during the day, and is that sabotaging your night? Are you on the right medication during the day? Are you on any other medications that might potentially cause sleepiness as a side effect? Are you not structuring your exercise routine with when you take your medications, thereby unfortunately not optimizing your use of the medication and fatiguing you even further? Or is this simply a reflection of progression? And there are a couple of medications out there that we sometimes use to help improve people's daytime fatigability, medications like modafinil. So these are all things that at least I look at when I'm seeing patients and hopefully try to address. Sometimes you can, sometimes you can't. And then the other big key factor is there mental health issues that's unfortunately sort of elevating that level of fatigue? So are we not treating depression, for example? So these are all the things that I look at least when it comes to fatigability in PD, which I think is a huge, huge factor. And I feel it's being amplified even more during this pandemic as we're socially and physically isolating ourselves. When it comes to holistic approaches to PD, I think that there is a great opportunity here for us to understand CAM a little bit better, right? Complementary and alternative medicine. And I know, Inda, you probably know this better than I do. But I think that when you look at lifestyle choices and lifestyle changes that need to be made in order to have people live better with their PD, it's not just about medical management. It's not just about personal sort of ownership, and it's not just about therapy. It's actually about adding in good nutritional input. And those folks who have already been doing that in their lives before their diagnosis are so much more likely to continue doing that even after the diagnosis. Having a positive attitude, I think, is actually quite important. It takes a little while for somebody, once they've gotten a diagnosis, to kind of, I don't know, absorb that diagnosis, not allow it to define you, but more or less, shadow you rather than define you. And so making that sort of philosophical shift in your own head to a more positive approach also opens up a few doors when it comes to, not just appropriate medical management, but also CAM type management as well. So those are the two pearls I'd probably want to convey, is that if you had been making appropriate, healthy lifestyle choices before a diagnosis, of course, many of you already on the call are already diagnosed. I get that. But even if you make them soon after the diagnosis, you're going to be much better for it, and you're going to thank yourself later. Good thing is that we live in, if most of you are on the call are from the West Coast, we live in areas that really do appreciate whole food type diets. I mean, in Northern California, we all love our fruits and nuts, and that's kind of, I think, a healthy thing. So it's not hard for me to be able to convey that to folks, and to kind of avoid some of the things they shouldn't be eating and maybe appropriate the things that they should. But bottom line is positive attitude, healthy lifestyle choices. If you've already been doing it, you're going to be better off for it.
Yeah, I think that, that pie that you showed, which is really cool. I think, just that the medications is like, I think it's less than 1/3. If we took out some of the piece of that pie for medications, we might add a complementary alternative medicine slice. And,
Right.
And I think positive attitude could, be in there as well, either in the empowerment, somewhere. But I think, we might relook at that pie, because I think that so many of the people that I've interviewed on this group here have talked about the attitude of the patient as so important. And I think, how to make that shift in people's minds, that this is something that, should not define them, and that they will, need to sort of think about it not as a terrible, horrible diagnosis, but something to sort of pivot and shift your mind a little bit in a different way, to maybe embracing some of these other tips that you're talking about. So we have just 5 minutes left together. I think, this has been really great. Maybe you could tell me a little bit about, the pandemic has been so, so, stressful on so many, but I think, I'm hopeful that we'll come out of this with some silver linings. Maybe you could tell me a little bit about your thoughts of silver linings from this pandemic that you've seen.
The silver lining that we speak about a lot in regards to the pandemic has been the use of telehealth, right? The fact that we're even having this type of meeting right now you can basically say is a silver lining of the pandemic, right? So many folks who were unfortunately put in the dark because of the pandemic have now started to recognize the need to be able to connect virtually, whether it be with their loved ones, with their provider, or with support organizations like this. So for me as a medical provider, the silver lining is going to be the utility and the optimization of that telehealth, whether it be support or medically driven. It also gives me the hope that we can reach a much wider audience, right? I mean, the thing is that traditionally medicine has always been delivered in person, right? You make an appointment. It may not be for a few months. You then come to the waiting room. You then wait in the waiting room for a little while. Then you maybe have to fight for a parking spot in the medical office. And then you come into the little room and you have to wait there for a little while too. And then you end up seeing the provider who probably has, 20 minutes, 30 minutes to see you. And yet you haven't seen him in a year or her in a year. And so that means that in the 20 minutes, that's all you have. And so I feel that if I can do more telehealth in some form or another, I'm going to reach people that otherwise couldn't drive up, didn't have to worry about the stress of having to park, wait in the waiting room, and then forget about what they wanted to talk about, right? And that they're actually comfortable in their own home setting. I can see them in their own home setting. I can see behind you, you got some wonderful books back there and some beautiful pictures of your family. It allows me to connect with my patients a little bit better. And I feel like I make a connection with it. You and Lori Michel have done some of that work together about those social connections. I get to actually witness a little bit about the patient's life in a way that I would never have been able to before, and with patients I was never able to before. So I'm hoping that even when the pandemic lifts, that we continue on this process of utilizing and leveraging telehealth to be able to reach a much, much wider audience. That's my takeaway.
That's amazing. Well, I think you've covered some very important, things. And I think, one of the things that, I learned some things from each of these sessions. And I think the concept that, some of our patients are, you said probably 20% at least that can't be reached through this virtual modality because they don't have access or whatever. I think we have to really think about how to access those patients still and get, this sort of internet to these places and, be able to teach them how to use this. Because I think that is, that some of the folks that were isolated and cut off are even more cut off if they can't, access some of these things. And I applaud you for keeping your doors open and being, able to see these patients. And I think that there are a number of our patients that have not thrived during this, sort of pandemic. And I think we're going to be seeing sort of the consequences of that, in the years probably to come. And so I think anything we can do to be proactive and think outside the box, as you have been doing, is really so important. Just going to give you the last minute to kind of wrap up, Suketu, and tell us maybe a message of hope, to our patients out there. I always like to end on that, and then we'll pass it back to Andrea.
Sure, absolutely. Actually, I'm probably most hopeful about just even on this meeting. I mean, you guys had nearly 100 participants. That's amazing. I mean, how many support groups or support programs in the past were able to, applaud themselves by having this many people join a virtual conversation between me and you? And I don't think I've talked to you for an hour like this by a video or by phone ever. It's always been in person at these meetings, right? I learned from this, you learned from this, we all gain a little bit of hope from this. And I think that this is really going to be a sign of things to come. So as much as I worry about the pandemic causing these crisis-driven care issues as we move forward, I also think that if we understand telehealth, if we understand the utility of support organizations like PMDA, that I think we're going to be okay. I hope we're going to be okay. That's my hope, actually.
Yeah, no, I think there's a lot to be learned, and I've some of the chat here. Hopefully, they'll share those with you after. But lots of positive messages. I'm supposedly Ken wants me to have you come back for 3 hours. We'll get your PT gal on as well, and maybe even the DBS person who runs the DBS support group. We could get some pearls from that too, because I think there's a lot of people who want to be able to participate in these amazing things that you guys have offered at Kaiser, and I think they're largely closed just to the group at Kaiser. But I think maybe we can learn some of the top tips from your your gang. So really appreciate it. Thanks so much. Andrea, I'm going to pass it back to you for our wave goodbye.
Well, thank you
We
so
always
much.
show our gratitude for spending an hour of education and socialization with a goodbye wave. So I invite everyone to turn on their camera. And Dr. Khandhar, if you scroll through in gallery view, you can see all the
Sure.
smiling faces of the people who are just so appreciative for this. So thank you to both of you.
Thank you
and
guys so much. This is wonderful.
Bye
Super
now,
fun. Nice to see you.
everyone.
Thank you.
All right. Thanks, Indu.
Mhm.
Bye.